Thank you for agreeing to speak with me today, Dr. Yankeelov. Could you share a little bit about what initially drew you to the field of mathematics and physics and how they led you to biomedical engineering?
Sure. Well, I don't know. When I was younger, I always just enjoyed math. It made a lot of sense to me. I liked, of course, like a lot of people, I liked that you could get an answer that you knew if you were right or wrong at the end of it. I liked that definitiveness of it. As I got older, I started to see the beauty in it, the idea of how it's really cool how you can use mathematics to explain things that happen in nature. The people frequently refer to it as the unreasonable effectiveness of mathematics to describe the natural world. That kind of thing was really cool. So I just really liked it. When I went to college, I actually went to college because I wanted to be a high school teacher of English. I wanted to be a literature teacher in high school. So I really wasn't thinking about math or physics or engineering. I just enjoyed doing it. So that's what I was studying in college. And then I saw that movie Jurassic Park. Did you ever see that movie when you're?
Yeah,
Yeah,
I
yeah. They talk about chaos theories, like what's that about? And so then I read the book Jurassic Park, and then my brother, who was older and an electrical engineer, said, "Oh, you got to read this book called Chaos by James Gleick." And so I read that book, and then I got really interested in mathematical modeling after that. And so then went into that world. When I was studying mathematics in graduate school, we had to pick an area of application because I was in applied math. And so I took a course in quantum mechanics, and I thought that was the coolest thing I ever saw. So I sort of straddled the math and physics departments for a few years, and then did an internship up in Brookhaven National Lab up in New York. And I saw someone give a seminar on magnetic resonance imaging, or MRI, and I thought that was super cool, and had big chunks of math modeling and physics and engineering in it. And so I went into that and started to use it to understand different properties of biology, and then eventually different properties of tumors. And so cancer at that point was really not mathematical modeling was really not part of the work in cancer. It was People had written down equations for how tumors grew for over 100 years, but no one had really ever started to link it to anything you could measure. It was all very theoretical work. So I thought that I had this background that maybe we could start to attack uh, how tumors grow and how they respond to therapy with a more rigorous approach, with the mathematical approach. And I remember once I was at the beach reading this historical review of meteorology. And it talked about how 100 years ago, there was no math or physics in meteorology. It was all just guesswork and experience of the person making the forecast. And I thought, boy, that sounds an awful lot like oncology now. There's no real math or physics in it. And so when I got back from the beach to the lab, we all got together from our team, and we went to the whiteboard, and we made a list of everything we could measure from medical imaging. And then we started to build these sort of mathematical models that could make use of those data. And so that's where it all sort of started to come together. We stole a lot of ideas and the philosophy of weather modeling. In weather modeling, meteorology, they have satellites and weather balloons and radar, these kinds of measurements. We don't have that, of course, in oncology, but we do have medical imaging and a host of other different types of measurements. And meteorology, they use those measurements to drive these things called the Navier-Stokes equations. In oncology, we really didn't have proper models that could be married to the data, so we kind of had to start building them our own. And there was a handful of other people who were also working on that, and around the country, around the world. And so we started to marry these ideas of medical imaging with mathematical models, and started to put those together to make predictive models of how tumors would grow and to respond. So that's a 50,000-foot view of how we landed where we are. Yeah.
So you mentioned along the way you had Jurassic Park and your brother as really great, like an experience and a mentor. Were there
Yeah.
any other experiences and mentors that at your time like Vanderbilt or UT Austin that helped guide the direction of your research?
Yeah, I mean, it started even earlier than that. It was my high school English teacher, Mr. Ricketts, who was the first teacher I really had who taught us all that, we could say whatever we wanted to in our essays and stuff, but we had to be able to back it up. So that notion of trusting what's inside you, but you can't just say it. You gotta back it up and show that it has value and meaning. That was kind of new to a lot of us at that age, I think. So that was a huge leap forward. Even before that, Mrs. Souza, my fifth grade science teacher, we had 3 chapters on the solar system, the galaxy, and the universe, and that was really the first time that I really was blown away about science and nature. So those 2 people were early. And then in college, again, an English professor, Dale Billingsley, Dr. Billingsley, who taught me how to write and communicate ideas at a much higher level than what I was used to doing before. And I think that probably helped us with our team's ability to write research papers and how to write grants and how to communicate these ideas to larger audiences. So that was really great. And in graduate school, I had a professor, Brian Surratt, Dr. Surratt, who was a nuclear physicist who taught us quantum mechanics, and he was a phenomenal instructor and really made very difficult concepts accessible to a lot of us with clarity and lots of examples and lots of different ways to explain the same thing from different directions. So if you didn't get it one way, you got another. That was really wonderful. When I was a postdoc, my postdoc advisor, John Gore, who is at Vanderbilt University still, directs the imaging center there. He had a real visionary who could pull ideas from many different places and had a whole way of thinking about imaging science as not separate subfields, is all one part of, MRI was not different than positron emission tomography, PET, which wasn't different than ultrasound. It was all under the heading of imaging science. And so had a more holistic or comprehensive view on what imaging was. And that idea of not dividing things into pieces, seeing how they connect at a higher level, I think was very helpful. And he introduced us to a lot of people, a lot of different ways of thinking, opened a lot of doors for us for our team. So those were some of the people that really along the way really were helpful. Yeah. Within the area of mathematical oncology itself, I remember being really influenced early on by 2 people in particular, Sandy Anderson at the Moffitt Cancer Center, who established this thing called this Integrative Mathematical Oncology Program at the Moffitt Cancer Center in Tampa Bay. And another person was Kristen Swanson, who I believe is at the Mayo Clinic in Arizona now. Those 2 people's early work really inspired me, and by extension, our team. Yeah.
So you mentioned a bit about how MRI PET imaging can really help with mathematical oncology.
Yeah.
Yeah. So what makes it specifically useful to studying cancer, or are there other medical imaging that can help with?
Yeah, medical imaging in general is really helpful for this because you can make measurements in 3 dimensions and at multiple time points, mostly non-invasively, without cutting into the patient. There is ionizing radiation for things like CT, PET, and SPECT. So we can't say it's completely non-invasive. We usually say minimally invasive. And then anytime a contrast agent or a radiopharmaceutical is injected, that requires a needle into the arm to deliver the contrast agent of radiopharmaceutical. So these are measurements that can be done at multiple time points and in 3 dimensions. So they can characterize the 3-dimensional nature of the tumor, and they have different ways of characterizing the tumor. So MRI is really good for high resolution anatomy, really good soft tissue contrast, but it can also tell you things about blood flow and cell density and hypoxia and other measurements. PET's really good because it can do true molecular imaging, to tell you about glucose metabolism or proliferation, hypoxia, cell surface receptors, these kinds of things. So these are all measurements that are super important for how tumors initiate, how they grow, how they invade, and how they respond to therapy. So they're really nice measurements to be used into a predictive mathematical model. In fact, the measurements that you get on your own just from those things, like I was talking about the cell density or the proliferation of hypoxia, those things just statistically can sometimes separate responders from non-responders. So there's an important signal there because you can separate responders from non-responders, for example. So that gives you a lot of motivation for trying to use that data in a predictive model. Yeah.
So you mentioned earlier how whether research like how the spatial temporal dynamics were really important to inspiring your work.
Mhm.
You also mentioned it in your recent article designing clinical trials for patients who are not average.
Oh, yes, yes, yeah, yeah.
So, what are like some of the key mathematical models involved in making a spatial temporal a model?
Yeah, so the general heading for these things, they're what we use are things called partial differential equations. These are things that have been around for centuries, but what they do is they track the dynamics of a system. So you might have, usually we call it a quantity of interest. So for us, that quantity of interest is frequently the number of tumor cells that are in the tumor. And partial differential equations, or PDEs as people call them, can characterize how those things, how the tumor cells are moving around in space, so in X, Y, and Z dimensions, as well as in time, T. So you can track how the tumor cells are moving or changing around in space and in time. So how these equations look is the left-hand side is this thing that it's a symbol, but it basically means how the tumor cells are moving in space and time. And then you have your equal sign, and on the right-hand side, the pieces are things about how they're migrating and how they're interacting with tissue mechanical properties and how they're proliferating and how they're responding to therapy. So those are like three components that we care about, like how they're migrating, how they're proliferating, and how they're responding to therapy. And so your measurements that you get from whatever imaging tech or whatever technique it is you use can help populate those parameters. And we use a lot of imaging data so we can make direct measurements that report on various aspects of those three things. And so you make those measurements and you populate the model, and whatever parameters you can't measure directly, those are parameters that you have to calibrate to the data. And since these models are dynamical models, they're designed to describe how systems are changing, we usually need at least 2 time points. So usually we measure before therapy starts, we make our imaging measurements before therapy starts, and then sometimes early in the course of therapy. It could be really early in the course of therapy, just a few weeks in. And so those 2 measurements we use to calibrate or fit the model to the parameters that we can't measure directly. After that calibration process is done, then all the model parameters are known, and then you can run the model forward in time to see how, given this initial condition of what the tumor conditions are, how does that change over time? And that lets you make your prediction about if the tumor's shrinking or growing or which way direction it's going or other quantities of interest about the tumor. And that's the prediction component. And since it's based on imaging data and you're not upsetting the system when you make the measurement, you can make a prediction and then compare it to a later imaging measurement to see if you were right. And so actually we've gotten pretty good at that. So so that's what's exciting, I think, about it.
Just to confirm, these are digital twins, right? Like the
Well, so that's thank you for asking that. So we haven't talked about digital twins yet. We've just talked about the mathematical model that lets you calibrate the data to make the prediction. The key thing, and that's a component of a digital twin, but the key things about digital twins are you have some mathematical model that describes the underlying physical processes of the system you're looking at, but you also want to use that um, uh, to predict and then optimize the behavior of the system. And then the other third thing is that there's this back and forth between the digital representation of the object and the real thing. So in our case, the thing we're trying to control, of course, is tumor growth. We want to slow, stop, or regress that. We want to optimize how the tumor is responding to therapy. Um, so, but we don't just treat a patient once, right? We treat them and they get treated again and again. And so you need to update your model. And so that's where the digital twin starts to have life breathed into it. So the idea is a patient presents with some initial set of characteristics, you calibrate your model, make your first prediction for what the best way you could intervene for this patient. You make that prediction, and then ideally you would then do that intervention. That's going to change the system over here, the real patient data. So you had to make another measurement to update your model to make a new prediction of the best way to intervene. Then you do that intervention that's going to change the system. So you got to make a new set of measurements. So there's this back and forth between the virtual representation of the patient or the tumor, and then the what's really happening in real life. That back and forth is the key thing. The field really hasn't gotten there yet. We know how to do this, mathematically or scientifically or engineering wise, but how you actually implement this in a clinical setting is difficult. We know how to do the predictions in the clinical setting and compare them to how a patient responds. We and others have done that, a fair amount of that now. now the question is can we prospectively have a patient come in, get your data, calibrate your model, make a prediction, and then optimize the intervention for that patient's specific situation, try that intervention on the patient, and then see if they do better than the standard way of treating a patient. That's kind of the next thing, right? Right now, when we treat a patient, it's sort of people sometimes say a one size fits all approach. Everybody with the same diagnosis gets the same intervention, and everybody knows that's not the best way to treat an individual patient. What's good for the average, it's really not the best for everybody because nobody is actually average. So getting this, moving away from the population-based intervention to a personalized intervention is where the field is really trying to go towards now. And these mathematical models is what's going to get us there, because you can't do trial and error on an individual. You have to have a way to compute the optimal intervention. A metaphor that I use a lot for people is when we put a new satellite in orbit, we don't shoot up 1,000 satellites and hope that one of them lands in the proper orbit. In 1687, Newton gave us the Principia, so we learned about F equals ma, and over the ensuing 240 some odd years, we have learned orbital mechanics. So now we build one rocket and we can compute where the thing goes, and most of the time it ends up in the right place. There, of course, are accidents, but most of the time it ends up in the right place, and you just send up one. We have to get to that point in oncology. We can't do this population-based approach where one size fits all, because it doesn't fit everybody. In fact, this is a bit over dramatic, but if you're designing a treatment plan to work best for the average patient, you're almost by definition designing it to work for nobody, because nobody is average. So there are people who are going to be close to the average, and so maybe it'll work better for them. But most patients, if you imagine a distribution, most patients are not close to the average. So we have to get away from this notion of treating the average patient to treating an individual patient. And mathematical modeling is the only way science has worked in any other field.
So you mentioned, like also in your articles that we can't use like large data sets or AI models to really individualize for patients. So how would you form like the equations for like
Yeah, so you should talk to other people about this, because I am very much in the minority about this, right? So there's two ways to think about this, or two extremes to computational modeling. On the one hand, there's the methods that are driven by artificial intelligence and big data that is everywhere at all times, being in the press and talking about and so forth. And so the other end of the spectrum where we work is mechanism-based models. Sometimes people call them physics-based models or biology-based models, and where you explicitly bake in the known physics or chemistry or biology into your problem. So you're building mathematical models that explicitly account for those. Whereas in artificial intelligence, you are rarely, if ever, incorporating the explicit known physics or biology of the problem. There are ways to integrate these two at the center, and we can talk about that. But on this extreme over here for AI and big data, every artificial intelligence method requires a population training set. It requires a set to train, for example, your neural network on, or whatever it is your machine learning algorithm is. You have to have a training set. And then you train your model, and then you have Miss Jane Doe who appears with her diagnosis. And if it's similar to the one that was the population that was used to train your machine learning algorithm, then you can use that to predict, for example, whether or not she's going to respond to this intervention. The problem is that cancer is so heterogeneous. It's not just one disease, right? It's somewhere north of 100, depending on how you parse it. So Miss Jane Doe isn't just diagnosed with cancer or breast cancer or triple negative breast cancer. It's one of the current 6 known subtypes of triple negative breast cancer, right? It's very specific. So in order to use a machine learning algorithm to figure out how to treat Miss Jane Doe, we have to have a population that is made up of thousands of people that has this specific subtype of cancer that Miss Jane Doe has. Also, that training set has to have all the possible ways that she could be treated. And those treatments have to have been given to those people that are representing her subtype. And that training set doesn't exist, and it will never exist, because the diseases are getting more and more specific, And the treatments are getting more and more specific because the biologists and biochemists are very good at their jobs and they're figuring out what's really driving these diseases. And so they're learning about it um, um, at a very fine level. So the divisions amongst the diseases are getting more and more specific, and then the therapies that are coming out of that knowledge are getting more and more specific. So one, building that training set is never going to happen. The other problem is that from person to person, the disease manifests itself so heterogeneously. If it didn't, cancer wouldn't be a problem. But why do two people who have the same diagnosis get the same treatment? Why does one of them do quite well and the other one do quite poorly? And quite well and quite poorly are euphemisms here. Why does one person get cured and why does somebody else pass, right? So these are due to the heterogeneity of the problem. And where AI and big data falls apart is when problems have lots of degrees of freedom, when there's lots of heterogeneity. If you need to figure out how many Toyota Camrys you need to ship to Des Moines, Iowa next year, then that's a beautiful problem for machine learning because there's not too many cars that look like Toyota Camrys, several dozen maybe. And there are a lot of cities that have similar purchasing patterns as Des Moines, Iowa. And so you can train on all the other cities and figure out how many Toyotas you need to send to Des Moines next year. And you know what? If you're wrong by a little bit, who cares? There's a few more Toyotas in Des Moines, and maybe your stockholders don't get as much money that year, but it's a smaller problem. But if you get this wrong for how to treat mom, or really worse, how to treat your child, then this is a major problem. And since there's so many degrees of freedom, because people are so different from person to person, I feel like this AI and big data stuff is fundamentally limited in what it can do for treating patients. In fact, or for optimizing the interventions for patients. In fact, if you haven't, I would encourage you to Google Watson Oncology failure. Watson Oncology failure. So IBM and teamed up with MD Anderson and spent somewhere around $40 million on this about a decade ago, a little over a decade ago, like 2010, 2012. And it was a total and complete failure by all accounts. The notion was that we would just feed in humanity's knowledge of cancer. We'd feed PubMed into some machine learning algorithm, and then we will be able to figure out how to treat Miss Jane Doe. And so if you look it up, you see that there were misdiagnoses, combinations of drugs were suggested that would kill patients. The whole thing was shuttered, it was closed down. So we've tried this. The notion now is we're better and smarter and we know more about neural networks or whatever. I'm being over dramatic here and painting this in one particular light, but we've already tried this. So I think AI and big data will be useful for things for simple tasks, simple quote tasks like parsing electronic medical records or helping with tissue segmentation on images. Things of that nature, like that. But how to optimize intervention for an individual patient, you got to care about their individual characteristics, and for that you need a mechanism-based model that explicitly accounts for those underlying mechanisms. Like I was talking earlier with our partial differential equation approach, it explicitly has terms in the model system that describe how the tumor cells are moving, how they're proliferating, how they're responding to therapy, different tissue mechanical properties, et cetera. Those things are explicitly accounted for. Whereas in an AI and big data approach, it is not explicitly accounted for. It's all requiring huge amounts of data to look for patterns in the data. And if your thing that you're trying to predict about is very specific and is not adequately covered in your training data set that was used to train the algorithm, then it's not going to work. And the argument is people are so very different that you can have gazillions of people in your training data set, but it's still not what Miss Jane Doe is experiencing. And so your prediction is always going to suffer. Yeah. But I should stress, I am very much in the minority about this. This is not a popular idea. So, yeah.
So I guess could you describe it sort of like the butterfly effect? Like there's a single butterfly in one scenario, not in the other. There's a hurricane in Texas for one, but not the other. If like the weather model sort of thing.
Well, yeah, I'm not certain how that applies here, Isaac. But yeah, I mean that's what the butterfly effect is based or is an effect that is observed in dynamical systems that are extremely sensitive to initial conditions. So if If the long-term behavior can be tied to the initial conditions, then then a system is not chaotic. But if the long-term behavior of a system is extremely sensitive to the initial conditions, then a butterfly flaps its wings. It changes the temperature or the pressure gradient or the wind velocity is very, very small amount. Then it sets the whole system off. And so after a certain amount of time, a hurricane is developed that wouldn't have otherwise, or something to that effect. So it is true that our models cannot predict indefinitely. And that brings us back to the digital twin thing, where the model has to be updated periodically with new measurements of the system, especially because you're intervening. Almost all cancer patients are treated. Very few people will say, I don't want to be treated. I'm just going to go and live out my days without having to deal with this. And that's a perfectly reasonable thing to do, and people do that. But most of the time, people will elect to be treated. So you're changing the system. So your model will make an initial prediction. You've intervened in some way with either radiation therapy or systemic therapy or surgery, a big insult to the system. That's going to change the system you're investigating. So you got to make more measurements to update your model. So we can't predict indefinitely from initial conditions. They have to be updated. In fact, we have a study going on now on the limits of predictability for our imaging-based mathematical oncology, and it's still ongoing. But it's probably going to be on the order of somewhere between 1 and 4 weeks is the best we can predict forward, before the model needs to be updated again. Yeah.
So what are some of the biggest challenges you have in implementing these models for clinical practice? Is
Yeah.
it
So go ahead. What are you saying?
is it like you have to keep on going in? It's like impossible to keep on predicting for like over 4 to 5 weeks.
Yeah, on that time frame, we have to make another measurement to update the model. But a lot of patients who are battling cancer do get imaged, somewhat frequently. So that's not a huge barrier. Right now, the barrier that we're having is how do we get, I alluded to it earlier, maybe I didn't say it very clear, is how do we prospectively test a digital twin that's driven by a mathematical model? What you'd really like to do to see if you could really improve outcomes is run a prospective clinical trial that's divided into 2 groups for some tumor type. Let's say it's let's pick a really horrible one like glioma, like brain cancer. And so one set of patients will get the standard of care therapy. The other set of patients will have their therapy optimized by a digital twin. So they will come in, they will have their measurements made, we'll calibrate our model, make a prediction, and then use something called optimal control theory to figure out the best way to deliver radiation therapy to this patient. And then we do that. They go up, they get that radiation treatment. They come back a week or 2 later. We get another set of measurements, update the model, figure out what the next best intervention is, and continue on that for their whole radiation therapy cycle. And then do those patients that have that's individualized intervention, do they outperform the patients over here who had the population-based one? That's the study that we really need to do. We're having lots of discussions about how to get this off the ground, but that's the sticking point, because the notion of changing the therapy on a patient-specific basis during therapy, that's anathema to a lot of treating physicians, and with good reason, right? There's a reason why physicians have to be conservative about this stuff, because it's untested and you're dealing with mom or dad or grandma or whatever. You have to be really conservative and really careful about these things. But at some point, we'll have to do this. We, meaning the field, well, not our team. I hope our team, we're trying to, but if somebody else does it, great. We as a field have to figure out how to do this, how to test this notion of a patient-specific intervention prospectively, and do that comparison I talked about between individualized intervention versus the standard of care. And we hold our breath and hope that the individualized outperform the standard of care. Yeah.
So how does collaboration in mathematical oncology look like for your research? And
Yeah, and what? Go ahead.
oh yeah, no, yeah, just like how would it function for testing out like digital twins versus non-digital twin patients and their outcomes?
Yeah. Well, it doesn't happen unless we collaborate. Like we have to collaborate both in the research side, we have people, who have their advanced training in engineering or in math or in biology, about biomedical engineering a lot. So we're interdisciplinary there. But if we just stop there, then it's largely an academic exercise. We have to work with a clinical oncologists and radiation oncologists and medical oncologists, radiation oncologists, surgical oncologists, because they're the ones, first of all, who responsible for the patient care. So they're the ones that give us access to patient data. So we partner with them on running these studies. They also do really important things like tell us what are the problems that they actually need solved, right? Because sometimes we think there's a problem that we go after and we discuss it with them. They're like, that's important, but it's not nearly as important as X. So let's go after X. So that's super helpful. And at the end of the day, they're the ones who are treating the patients, who are ordering the treatment for the patient. So they have to be involved. So that's actually a rate. I actually think now getting digital twins into the clinic is now much more a logistical kind of thing rather than a technological one. Like how do you explain to a in the trenches practicing oncologist every day that we need to guide their intervention for this individual patient based on this notion of a mathematical model? That's sort of bizarre, right? And then just as importantly, how do you communicate this to the patients? Like their treatment is going to be guided by a mathematical model. What do you mean? Wait, hold on. These are things that have to be navigated delicately and carefully. So, and we have to do more other logistical things like how we need to rapidly get the data from when it was acquired onto our machines to do our calibration and our prediction, and then send it back to the electronic medical record so that the treating team can look at it. And how do you construct a report, like in the same way that a radiologist does a read of images to form a report that the treating physicians can then look at? Same for pathology. There's a pathology report. How are those things? Those things have been developed over many years, and so there's a structure for that. So what's the what's the structure for a digital twin report? We actually have an early version of that circulating with some of our clinical colleagues to see if this is, how would they want these predictive models presented to them? What would be the most useful way to do it? And they're easy questions to say out loud, but they are hard questions to answer. So those kinds of logistical things ties back to your notion on collaboration. You absolutely positively have to have clinician buy-in and interest and champions of this, because they're the end user of it, and it has to be useful for them. Otherwise, it's an academic exercise, which is interesting and useful on its own, but it limits the impact one could have. Yeah.
So two last questions. What advice would you give to high school students who are interested in going to a career that combines math with medical sciences?
Yeah, well, I would suggest that you keep a notebook and you write every time you see something that looks of interest to you, you jot it down or say it into your phone or type it into your phone. And then later on, go and watch a quick YouTube video on it or get a book about it, or interview somebody who's in that field. What is it about the field that they like? What's their daily day like? Now is the time to sort of pop in on all of these different fields and see if they are of interest to you. So, I was interested in, I didn't say this earlier, but I ended up in math because I liked so much of science and I couldn't pick which one. So I thought I'll just study what's at the center. So I'll study mathematics, and later on I can figure out what I want to study. At least that's how it played out for me. So, but I read books on anthropology, on meteorology, on archaeology, on being a physician. I explored being a physician for a very long time. So I talk to people in all of these different fields. So I would definitely suggest, you read a book on what it's like to be a physicist or a physician or a chemist or a biologist or whatever. And, watch YouTube videos on this and talk to friends and family members who are in this field and ask them what they like or don't like about their job. I'd also encourage everybody who wants to go into STEM in some way to have friends and interests outside of science and engineering and math. To make it more STEAM, add in that A for arts, and because that helps develop the other side of your brain, which helps your creativity, which makes you a better scientist, engineer, mathematician, or a physician. Also, it helps you communicate your ideas better, because in order for these things to have maximal impact, you'll have to be explaining your ideas to policymakers who maybe don't have that much training in the STEM. So if you can contribute that, if you can develop that communication skills, then you're going to make a bigger contribution. So, consider taking improv classes or any kind of art in general, anything that will develop that side of your brain, and make sure that you have friends who are uh, interested in areas other than math and science. Those are the two sets of things I would suggest. Explore all the things via YouTube or books, and talking to friends and parents of friends and family members who are in the field to see what it's really like. And then also make sure you develop the other side of your brain. Develop the artistic side, the creative side, because that will make you a better scientist. It'll make you a better communicator. It'll increase your impact.
In the next several years, if you could have one breakthrough in any part of your research, what would it be?
Uh, Very specifically, can I say two things? One is logistical and one is more scientific. Scientifically, we need to get much better at both imaging and modeling the effects of immunotherapy. Immunotherapy is a phenomenal development in our arsenal against cancer. And when it works, it is phenomenal. And when it doesn't work, we don't know why. And a priori, we don't know which patients are going to respond and which ones aren't. And our current biomarkers for which ones will respond and which ones don't are not sufficient. So it's extremely expensive. There can be lots of side effects. And if it's not working, then it's not worth it. And we have very poor mathematical understanding of this. And we have, I would say, very poor imaging capabilities on the effects of immunotherapy right now. So I really hope that's an area where the field breaks through, because that, the whole notion of harnessing your body's immune system to fight this thing, that's very attractive, and makes a lot of sense. And it works in a lot of cases. But in the cases it doesn't work, why is it the case? And can we predict ahead of time who those patients are and why? So I feel like that's a big scientific thing. And then logistically, I really hope in the next 5 years we can do that prospective study that I was talking about, a digital twin guide, individualized intervention versus standard of care population-based approach. I hope that we can do that study, and I hope that it shows that individualized care outperforms population-based care, because that would break down a whole wall, and it would change the way we think about treating patients. Yeah.
Okay, thank you so much for agreeing to speak with me today.
Mhm.
I'm going to stop the recording.